Recording in progress.
Good evening, everyone. I am Dr. Amit Gupta, Joint Secretary of Diabetes India, and it is my proud privilege to welcome all of you for this fourth day of learning from EASD, brought to you by Diabetes India. And today we have a very esteemed panel with us and esteemed speakers with us. We have Dr. Leszek from Poland. He is going to talk about hypoglycemia and DKA. And we have Dr. Shashank Joshi, who is going to bring the latest updates from NSLD from the ESD. And we have Dr. Atul Kurushesht, who is a senior physician and diabetologist based in Agra. And he is going to conduct the panel discussion along with the esteemed panelists. We have Dr. Jargar with us. We have Dr. Tejas Shah with us. We have Dr. N.K. Singh with us. So I would like to briefly welcome all the esteemed panelists and speakers for today's program. And we have Dr. Bansi Sabu and Dr. Vishal, who is going to give vote of thanks for this program today. Bansi is currently
facing... I don't know what is happening, why my video is not coming.
Sir, you are audible, okay. but
yeah, I know, but it is, suddenly it was showing just before some time and now it is not showing. So, can you please, formally, I am welcoming everyone, and on behalf of Diabetes India, this what we thought during the ESD only. This time we were having Diabetes India Symposia also, and we thought that immediately after ESD, we should have learnings from ESD. Many of our experts who were there and what we learned, and immediately we should pass this message to all our people who are in India, and everyone can't afford to go to ESD meeting. This time we were having almost 100 delegates and many more faculties from India also. So we represented India very well in ESD. And thanks to Leszek and for all the support to Diabetes India, Indian delegates and Indian faculty member. And thank you again to you that you agreed to give a talk online, because every day we are getting almost 1,500 doctors who live join, they join live. And at the same time, around 3,000 delegates who are registered for this meeting, they will listen you later when they will get the time. So this is what we are getting the response from learnings from ESD. With these few words, without wasting much time, I will request Leszek to start his talk. And then we will invite Dr. Shashank Joshi to give his talk. And then later on, Atul Kurushesht will discuss with the esteemed panelist. Over to Amit and Leszek. Thank you.
Yes, thank you, Dr. Bansi sir, for your comment. And today is also a very special day because we are also going to release a video of Diabetes India 2025 Congress in this program only. So stay tuned with us. And now, Dr. Leszek, please proceed with your talk. Thank you for accepting the invitation.
Thank you very much. It's, as always, great pleasure to be with you. We have been meeting many times during the meeting in Madrid. The Indian representation was very visible and also very active. There was a very interesting session, as Bansi mentioned, from Diabetes India. We have also created a global ESD council to try to make ESD more impactful, to have greater reach worldwide. And Bansi is one of the members representing your part of the world. There are 12 members from Brazil to Australia. So that's yet another interesting initiative, just putting us all together and trying to collaborate even more. So thank you very much for this invitation. I would like to share data from two events or on two occasions regarding to the title of my talk. So I will be talking about the session I was chairing on hypoglycemia and DKA, but also I will direct you to the best currently paper on hyperglycemic emergencies, especially DKA, how to treat it. This is the paper every diabetologist, be it young or very mature, should know. So, and I'm talking to you from my hometown, from Łódź. I work in Warsaw, which is Polish capital, but I live in another city, and I'm just between the visits of my patients in the office. So if you arrived to Madrid, this is what you would see going to the conference center. And what we also have seen with some surprise, is that a huge fairgrounds in Madrid, the conference center was here down at the back. We had to walk at least half a mile. They were moving pavements as well, but have to walk quite a long distance from the tube station, which was supposedly to our health, which was great, but was also a little bit time consuming. So I was sharing a session, as you can see here, with a title on up or down and back. So what happens when glucose goes high or low and how to get back. And I will just show you 2 or 3 papers from this session. Not all of them were very interesting, but some of them were intriguing. Interestingly, almost all presentations came from UK. So the British are the ones who study hypoglycemia, hospitalization for hypoglycemia for DKA most often. So this is the study which is called Decode Hypoglycemia Study. And this was a very simple observation of almost 600 episodes of hypoglycemia, patients who were hospitalized in several centers. And what was interesting here, that the main reasons for hypoglycemia in adult patients, mostly with type 2 diabetes, were either for problem, sorry, it's here, shown here. It was either insulin overdose or not taking a meal. So very popular things which we can eliminate with a discussion. This is the reaction which was made by the doctors. Mostly insulin dose was reduced, but in some patients insulin was stopped. But what was especially striking, and we were all surprised during the session, that close to every 5th hospitalization for hypoglycemia ended with death. So this is not a trivial complications. We as diabetologists are very much used to hypos, but if a hypos is severe and the patient comes to a hospital, then there is a risk that he or she will not leave a hospital. Not, of course, only because of hypoglycemia. Hypoglycemia is often a marker of a general health condition, or hypoglycemia is caused by concomitant diseases. Still, it should be really an emergency and a warning for doctors that the elderly patient is admitted to the hospital with hypoglycemia. The median age, as you can see here, was 75. Majority was with type 2. So patients who are elderly, hypoglycemia, hospitalization, every 6th patient dies when hospitalized in UK. And we all think that, and probably rightly so, that the English healthcare system is the one we would like to have. So the message in general from the study, and you can see some eminent authors, Pratik Chaudhary, whom we all know, the paper was about not the management of hypoglycemia, which was not optimal. And this not optimal thing was either not referring to a specialist or not educating patient sufficiently. So hypo is still a very dangerous thing, or here is seen even better. So these are the reasons for hypoglycemia. The problem was, as I said, meal or insulin misalignment. This is how we can call it. And as I said, it's easily removable with proper education. Another study, also coming from Pratik Chaudhary group, was on hypoglycemic events during the day in patients who were wearing CGM with type 1 diabetes, how they cope, how long hypoglycemic episode lasts. And in another paper, which I will show you, there are results shown how it affects heart rate during the day. The common thinking is that hypoglycemia causes arrhythmias and may cause sudden death, especially at nighttime, but I'll show you the data from the day. But before I go to this, please have a look at how long does an hypoglycemic episode with blood glucose below 70 or a more severe below 54 last during the day. This is the yellow curve, or during the night. And the nighttime episodes are longer, even for 1 hour. below 70, below 54, half an hour. So they are not trivial and they are not missed by, of course, by CGM. But the paper of this, the purpose of the study was to analyze if a patient had hypoglycemia during the night, what happened with the glucose in a following day. Again, the stereotyping thinking is that the patient, we all know Chomolki effect, that if you have a hypoglycemia during the night, you may expect hyperglycemia in the morning or during the day. And what they observed was actually quite opposite. If you look here, if patient had hypoglycemia, these are the days after the nights without or with hypos. And look at the time below 70 during the day. So the patients who had hypoglycemia at night had a 1% longer time in hypoglycemia during the following day. But this is especially interesting. The bottom line, the bottom figure here, the figures at the bottom of this picture, that in the morning, patients who in a day following the night with a hypo had more or less by 1.5 millimole lower glucose. So it's not, if we see the implication of the study is that if we see lower glucose in the patients while fasting glucose in the morning, it doesn't mean that during the day was okay. The patient might have hypoglycemia during the night, and this caused also lower glucose in the morning. The Chomolki effect was described when animal insulins were used, where they had their peak time of action around 2, 3, 4 a.m. Nowadays, we use more stable insulins, and with them having hypo at night increases the risk of hypo during the day. So that's, we believe, is an interesting and practical finding. And again, Pratik's name, you can see here, the investigation on how hypoglycemia affects heart rate in symptomatic and asymptomatic hypoglycemia during the day. And this is a large study, hypometric study. The patients who were analyzed are shown here, and these acronyms means this is sensor-detected hypoglycemia. So hypoglycemia only seen in glucose monitoring. This is PR, is patient-reported hypoglycemia. So the patient knew or felt that he had hypo. These are the patients, and this is quite a large number, over half of the whole group, almost half of the whole group, patients who had both. Patients felt hypoglycemia, and it was confirmed by the sensor. These three groups are important because we do make a difference between hypoglycemia, which is only seen in CGMS, or reported by the patients like here on the right. And if we look at the effect on heart rhythm, this is the moment of hypoglycemia during the day. And we have different groups here. This is the heart rate shown by red in bottom by the patients when the hypoglycemia were reported by the patients. This is by the sensor. This is both with symptoms or without. But the most important message from this figure is that hypo during the day, as it happened here, does not affect heart rhythm, heart rate during the following half an hour, 30 minutes. So this is unlike what we would expect. The explanation for this finding is, and this was shown in the discussion during the session, that the reports we know about this detrimental effect of hypoglycemia or on heart rate, they comes from the night, and these are usually those hypos were much more severe, and they cause the reaction of the hormones. Here during the day, those hypos were not so severe, and it did not affect heart rate. Practical implication, very simple. If a patient feels that the heart is going very wide, it doesn't necessarily mean that this is hypo, because that will not be usually seen or appear in patients during the day. This is in type, the picture I showed you before was type 1. This is type 2. Again, similar reaction, or rather lack of reaction to hypoglycemia. So those symptoms of hypo are not necessarily related to heart rate, unless probably hypoglycemia is very severe. And the last paper I wanted to show from the study is not necessarily about hypo or DKA, but is about the risk of hypoglycemia. We all struggle with a proper classification of diabetes. There were sessions at the EASD devoted to the concept of clusters of type 2 diabetes. We talk about 5 clusters now. We call them Alquist clusters. Emma Alquist is a Swedish investigator who described several years ago the concept of those clusters. But we also struggle in differentiating between type 2 and type 1 diabetes. And of course, it's obviously important for the patients for the choice of treatment. So what they did here, this is again a British study, they prepared a special model, which they called T1, and they took a very basic clinical features of the patients and came to the conclusion then among patients with type 2 diabetes, about 2% of them has a high risk, so above 70% of not being type 2. So we may assume that about 1 in 50 patients with type 2 diabetes is actually type 1. These were the patients who required insulin much more often during the first year after the diagnosis. And the other way around, patients who have diagnosis of type 1, that's very interesting. Patients who have diagnosis of type 1, apparently 13% of them are likely not to be type 1. It's interestingly how this answer we didn't get, how this type 1 was diagnosed here, because if you measure autoantibodies, we are sure this is type 1. So here, about 6th, 7th patients with type 1 apparently was not, or likely not to be type 1, or it was a very slowly developing type 1. They also analyzed the patients, those who were not properly diagnosed as type 2, they had much more higher risk of being diagnosed, of being hospitalized with DKA or hypoglycemia. So one of the ways to prevent hypos or hyperglycemic emergencies is to classify diagnosed diabetes properly. And we are all more likely to say, oh, this is type 2, then this is type 1, because type 2 is so prevalent. I can say from what we see in Europe, in my country as well, we see more and more patients with type 1 who are obese. And the people think, oh, that must be type 2, but actually, when we measure autoantibodies, this is type 1. So finally, I would like to point your attention to the paper which was published in a paper version of Diabetologia, our European journal, in August, just last month. This paper was online since June, on hyperglycemic crises in adults with diabetes, a consensus report. And the paper is really signed by ADA and EASD. We have, it's a very clear, very well written paper. And the first author, you must have known the name, is Guillermo Umpierrez. This is #1 globally, worldwide, on diabetes in hospital. Bulk of his research is on patients with diabetes in hospital. So we will find a very clear, it doesn't look clear, but if you look carefully, I have no time to go through it, and we all know it basically as practitioners, the very clear figure showing how DKA or hyperglycemic hyperosmolar state develop in patients with diabetes. We have a little bit changed diagnosis for DKA and hyperosmolar hyperglycemic state. This osmolality has changed here. Beta hydroxybutyrate has been added to the diagnosis. So this was not used before, especially that this level of 3 was also suggested earlier to be different. So new diagnosis, which may be again useful in deciding how a patient should be treated. And this is the figure I guess we all know very well. It is replicated in many local guidelines or how to treat DKA or hyperglycemic hypercondition, hyperosmolar state. We have a very similar algorithm in Poland with slight differences. Those indications to stop insulin, for example, we have at 3, not 3.5, but nevertheless, in one figure, a very clear guidelines how to treat DKA, which still happens and still is burdened with some mortality, especially in low or middle income countries, because the patients there with DKA are hospitalized a little bit later than on average worldwide. And the last thing, when we talk about DKA, very clear message from Madrid also came, and there was a whole session about it, and the paper on it was published in September issue of Diabetologia. We have now a consensus on what to do with the patients with autoantibodies, but in whom glucose is yet okay. So a very early stage of type 1 diabetes. I must say that some time ago, I was not really supportive of screening for type 1. There's a constant discussion, should we measure autoantibodies in all patients with newly diagnosed diabetes? But the data from Scandinavia mostly show that if we know that someone has elevated anti-GAD antibodies or any other antibodies, still having normal glucose, these patients are diagnosed with clinically overt type 1 diabetes without progressing to DKA. So that decreases hospitalizations, that decreases the risk of developing severe condition in patients. So another message is, and this is where the world, like Europe, like USA, the direction which is going is to slowly recommend. It hasn't happened yet, so don't think we should do it now yet, but it may change within the next 3-5 years, that it will be recommended to measure autoantibodies in every adult patient with newly diagnosed diabetes, because that will help to diagnose type 1s early and then prevent DKAs. So thank you very much for your attention. Just a final picture. The main topic in Madrid were incretins, GLP-1 analogs, obesity, and this obesity was even present in some of the posters here. As you can see, annual also got a little bit obese. We had 3 N's instead of 2. So I wasn't talking about it, but you were mentioning during the last 2 days, and I'm pretty sure it will be discussed also today. Thank you very much for your attention.
Thank you, Dr. Leszek, for your nice presentation. And there were a lot of learning points in your presentation, and I'm sure we'll be having a lot of discussion around that. May I request Dr. Atul sir, can we proceed with Dr. Shashank Joshi's talk first, and then we can initiate the panel discussion?
Right, sir. It is my pleasure. Yeah, it's my pleasure to introduce Dr. Shashank Joshi. He is a known figure from not only from India, for all over the world. He is having a very much command on his presentation, and I am lucky to have to chairing this session of Dr. Shashank Joshi. Now, today he will be speaking on, I think, metabolic associated liver disease, MASLD. Dr. Shashank is a consultant endocrinologist from Mumbai, and he has published lots of papers, more than 1,000 publications. And look, any of the diabetes book all over the world, there is chapter by Dr. Shashank Joshi. He is a very good orator, and for his work, especially in this young age, he has been awarded a Padma Shri by Government of India. Now over to Dr. Shashank Joshi for his presentation.
Team, may I request you to please play the recorded talk of Dr. Shashank now.
Hello, everybody. I'm grateful that the EASD and the Diabetic Cardiovascular Study Group of EASD allowed me to speak on this topic, targeting MAFLD or MASLD for cardiovascular prevention. I don't have any duality or conflict of interest for this talk. We know that this entire spectrum of fatty liver disease is moving the gear from a healthy liver to metabolic dysregulation, cell death, NAFLD, to chronic inflammation and fibrosis. And it is that fibrosis to cirrhosis to end-stage liver disease, which is the key. But the N word of non-alcoholic fatty liver disease has been replaced by the M word, metabolic. And the intersections are with the new word are some shared features. For example, the shared features are insulin resistance and fat accumulation. And then, of course, we have the high fat diet, the genomic factors, the glucose and lipotoxicity, the reactive oxygen species, and all of them are nothing but the metabolic associated steatotic liver disease is overweight and presence of type 2 diabetes, which is the most important criteria. So there was a Delphi consensus, and they clearly evolved that there is a need to change because the word non-alcoholic was stigmatized, the word fatty was stigmatized, and therefore a non-stigmatizing description was the advantage of MAFLD and MASLD, and a combined factor was MET-ALD, which means there could be a little bit of alcohol, little bit of metabolism. So that labeling has been done. So when we look at hepatic steatosis in adults, we have biomarkers, we have a liquid biopsy in imaging, and then we have a liver biopsy, and that is how the mechanism occurs. And this is the classical pathway, the MASLD, which eventually leads to MASH. Then we have a based on whether it is MASLD predominant or ALD predominant, based on the amount of alcohol which is consumed weekly or daily. Then, of course, we have ALD. Then we have specific etiology SLD, like a drug-induced liver disease or a monogenic disease. And then, of course, we have cryptogenic SLD. But the cardiometabolic criteria now form the key feature of steatotic liver disease. And if there are these cardiometabolic criteria, 1 out of 5, like a BMI, waist circumference, high glucose, A1C, or treatment of type 2 diabetes, blood pressure or antihypertensive treatment, elevated triglyceride or lipid lowering treatment, low HDL or a lipid modulating treatment for adults, and similar criteria for children, then you can categorize them into this category. So metabolic syndrome is the key for this entire continuum. And in this entire key for the metabolic syndrome, we have environmental factors, genetic factors, MASLD factors, and that leads to a liver pancreas cycle, which is classically there. So Professor Kusi called this triangle of care. And in the triangle of care, we have heart disease, kidney disease, and liver disease. And that is the modern cardiometabolic risk reduction of triangle of care, where we have agents which can attack them. For example, for the liver, PIO goes up the order with GLP-1, SGLT2, and GLP-1s. While for heart disease and nephropathy, there are similar agents. And clearly, they have a linear relationship. Because when we plot the natural history of liver disease, then you can clearly see that there's a linear relationship towards progression, and that is something recognized. So MASLD is a worldwide disease, and the global prevalence is 67%, and prevalence of MASH with type 2 diabetes is 41%. So people living with type 2 diabetes have 41% of them have MASH, and 67% have them MASLD. And it is the cardiovascular complications which is driving the endothelial dysfunction, whether it's a stroke, heart failure, arrhythmias, myocardial infarction, atherosclerosis, and so on and so forth. We have different ways to check it out. For example, we can do the FIB-4 score with platelet count, EASD, FIB index, fibrosis scores. We can do elastography, CT, MR, or ultrasound fibroscans. We can even do a biopsy, and then we can adopt lifestyle measures. So the simplest algorithm which ADA recommends is do a non-invasive FIB score. If it is low risk, then just forget about it. Do it every 2 to 3 years. If it's intermediate risk or high risk, then do an ELF blood test, which is a simple biomarker, or do a vibration controlled transient elastography or sonography. If it is again low risk, then you can do it after 2 to 3 years. If it is high risk, then you need to go to a liver specialist. But now endocrinologists are intersecting with the liver specialist, and the heart and liver is connected. It can lead to hypertension, coronary artery disease, cardiac arrhythmias, and cardiometabolic disease. So if there is perivascular fat, peripancreatic fat, pericardial fat, epicardial fat, fat around kidneys, skeletal muscles, and other organs, those visceral fat deposits confer a cardiometabolic risk. And somebody who has MFLD or MASH, it is clear that they have more vulnerable plaques. Their plaques are more likely to rupture. They are more likely to have coronary events. They are more likely to deteriorate. They are more likely to have heart failure and arrhythmias, and they are more likely to die. So that's the red flag. And that's why this topic. And obviously, this is the entire cross-section of pathophysiology linking MFLD with cardiovascular disease. But the key is EAT, epicardial adipose tissue. Because we know that this is the EAT, which is lipids accumulated between visceral layer of epicardium and myocardium, which is actually leading to the coronary artery disease, the atrial fibrillation, the heart failure. And that's something which we need to recognize. There's a direct linkage between hypertension and FIB score. And we know occurrence of hypertension is more frequent with the degree of steatosis. Occurrence of coronary artery disease is also more frequent with the degree of steatosis. Occurrence of cardiac arrhythmia is also more frequent. And occurrence of heart failure is also more frequent. So there is adequate global data published in this direction. And there are several studies which link cardiovascular disease, coronary artery disease, stroke, and so on and so forth. And clearly that is something there. One unique feature, which is a new point, which everybody should know, is the bile acids. Bile acids have a critical role in lipid digestion. They are signaling molecules regulating glucose and lipid metabolism. They influence the gut microbiomes. And they are crucial mediators and links between cardiovascular health, which influence vascular tone, cholesterol homeostasis, and inflammatory responses. And the cardioprotective or cardiac harmful effects of biliary acids depend on the concentration and composition of circulation. So if you look at the various bile acids, for example, the 12-alpha hydroxylate bile acids like TDCA, GDCA, they are in the hepatic stellate cells and they create a pro-fibrinogenic environment. So if there is a liver bile acid signaling defect, that will lead to local and systemic disturbances in glucose and lipid metabolism, increasing the cardiometabolic risk. And this presence of hepatic inflammation is thought to contribute to the hepatic bile acid metabolism and synthesis, leading to an intrahepatic biliary acid concentration, and that will propel mitochondrial sets, increase 7-HOCA, and lead to cardiotoxicity and lead to cardiovascular disease and heart disease. So that is the mechanism, biochemical mechanism. And therefore, the bile acids and bile acid signaling pathways are deranged in people with obesity associated metabolic function. The FXR receptor activation by bile acids has a protective role in cardiometabolic health, regulating lipid and glucose metabolism. And given the complex and multifactorial nature of steatotic liver disease and MASH, we need to combine FXR agonists with lipid regulators, insulin sensitizers like glitazones or GLP-1 analogs to manage the lipid pathways. Of course, when we assess cardiologically, there are non-modifiable factors, modifiable factors, and we can risk them like a Q-risk score, calculator, score 2 calculators, and we can actually plot low risk, moderate risk, high risk, very high risk. And all the global guidelines, including the European Society of Cardiology, says that if there is a person with type 2 diabetes without symptomatic or severe target organ damage, please estimate the cardiovascular risk. It is very high. And this is data to suggest the link between MAFLD and atherosclerotic vascular disk. The word N is used here because the data is published when the word N was being prevalent. And you can see several studies, cross-sectional, retrospective, prospective, meta-analysis are all there. How do we manage MFLD? From a cardiometabolic standpoint, with standards of care, ADA says you can make them lose weight with physical activity and structured nutritional plan, give them GLP-1 receptor agents, you can give them pioglitazone. So those are the pecking order top 2 agents, GLP-1 agents and pioglitazone. Insulin can be given with decompensated disease. Statin therapy is safe in compensated disease, but not in decompensated disease. And surgery in bariatric surgery can be considered in severe cases. So clearly the pathways are very well delineated. And if you have the conundrum of liver disease, type 2 diabetes, CKD, hypertension, cardiovascular risk, metformin with or without a GLP-1 agent, with or without a pioglitazone, with or without an SGLT2 inhibitors are the standard of care. And they should be co-complemented with a low dose of aspirin with statin. And that is really the standard of care. So clearly we have now very good treatment options. For healthy liver, we need to maintain cardiovascular risk factors and de-addict ourselves and do lifestyle. For liver fat reduction, we have lifestyle. We have PPAR alpha and gamma agents like a saroglitazar or a pioglitazone or incretins or SGLT2 inhibitors or thyroid hormone beta agonists. For NASH improvement or resolution, we again have lifestyle or surgery, pioglitazone or saroglitazar, incretin agents, sometimes vitamin E is used, and thyroid hormone receptor beta agents. And for fibrosis improvement, data is blurred, and that data will emerge in times to come. So clearly, we have to look at the liver angle when we are managing obesity, diabetes, dyslipidemia, and hypertension. And that's an important element. Behavior is the key, and behavioral intervention is the key. In fact, we have shown and I have published this data where a digital twin enabled personalized nutrition through a twin program, we have been able to actually, after a 1 year RCT, significantly improve not only the glucose, but all the surrogate markers of MFLD and MRI, the PDFF. So we can actually chop off the liver fat by using the magnetic resonance imaging derived photon density fat fraction, the PDFF. And we have shown that in a statistically significant way. So also know that pemfibrate is a PPAR alpha agent, like we have saroglitazar from India, which modulates the AMP kinase, and that's a new agent which is coming up. Statins, as I said, in steatosis, in inflammation, in fibrosis can be used. But once portal hypertension or carcinogenesis sets in, we'll have to be cautious. And therefore, there are several drugs which are now emerging in this entire space and spectrum. And we need to protect the vascular endothelium. And whether it is a GLP-1 receptor agent, SGLT2 inhibitors, which are fast competing in this space with a PIO or a SARO, we need to be mindful of it. So SGLT2 inhibitors are here to stay. They are available, they are off-label. This is the data of SGLT2 inhibitors which has been published. Pioglitazone is a level 1 agent. It is again here to stay, but it needs to be handled with care because this is the data of Pio again, which is very much there. So remember, cardiovascular risk is already increased when there's early MFLD. And when there is MASH or F3, F4 or MFLD patients with concomitant type 2 diabetes, it's a high risk for cardiovascular events and mortality. And therefore, diagnosis of MAFLD, you have to be CV vigilant, cardiovascular vigilant. Lifestyle is the key. We can do AI-based enabled twin-like programs, and there are specific drugs now. Whether it's a PIO or a GLP-1, whether it's a SARO or a new agent, these agents are here to stay. So whether it's a SGLT2 inhibitor, GLP-1 receptor agent, pioglitazone, metformin, or a saroglitazar, all of them are here to, even a vitamin E has data on it. So clearly we need to recognize that liver is a seat for focus for cardiovascular prevention. And in the triangle of care, we have moved away from cardio-renal protection to a triangle of cardio, renal, and hepatic protection. And that's really the sense of my talk. Thank you so much for a patient.
Thank you, Dr. Banshi, for a very lucid presentation on MASLD. Now, we are starting the panel discussion on that. For this, we are having 3 eminent panelists. My brother, Dr. A.H. Jargar from Srinagar, Dr. N.K. Singh from Dhanbad, and Dr. Tejas Shah from the Mumbai, 3 corners of the India. Now, first, Dr. Lesjak, first question to Dr. Jargar, sir. Dr. Lesjak has clearly mentioned that the study from the UK, Birmingham, that incidence of hypoglycemia was very high in the senior citizen above 75 years of age, and very high mortality, that is more than 20%. So, sir, in the most common drug today we are using in Southeast Asian region is sulfonylureas, whether patient is elderly or non-elderly. Sir, what do you think about this effect of SUs in elderly population to reduce hypoglycemic risk, whether it is to be continued or it is to be replaced by the newer drugs? What is your opinion as far as the Southeast Asian countries are concerned?
Well, thank you very
Atul,
much.
I think
I think this is an important question, and it's not only about Southeast Asia, because sulfonylureas are still used worldwide, also in my country. The benefits are two, they are cheap, and we know them very well. The key thing with sulfonylurea, the modern sulfonylurea nowadays, like glimepiride or glycoside, is to use them wisely. And wisely means not to use them in patients at high risk of hypoglycemia. And number one, high risk are the patients with kidney failure, even mild kidney failure, and also in patients who are frail. The mistake we often make in the elderly, especially really old people like over 80 years of age, sometimes the patients want it themselves. They try to get to the really low levels of glucose like normoglycemia. This is not necessary. We are happy when our patients have blood glucose of 8, 8.5, 9 when they are 80 plus or 75 plus. So in really, what often happens is that in the elderly, we decrease the number of drugs. We simplify the therapy. We do not overtreat them. So that's something to remember. But sulfonylureas, if you look at the rate of hypos on sulfonylureas, they are, of course, higher than on incretin agents or SGLT2s. But those two new ones, which I mentioned, glimepiride, glyclazide, if we remember about the limitations, they are okay. One of the very important issues, which was also the session on the future of diabetes, the session which ended Madrid meeting, it was David D'Alessio from US who had the talk on the future of diabetes. He didn't talk about the drugs so much. He talked about the access to the drugs and affordability of the drugs. We can have most wonderful drugs in the world, but if the patient cannot pay for them, we don't really need them. Yes, we can't use them. So, no, I don't think I'm not a strong defender of sulfonylurea because we do have better options which do not cause hypoglycemia, but we still use them a lot and we will be using. So, insulin is a different matter. Insulin is much more likely, of course, to cause hypoglycemia. And the challenge we are having, I guess, everywhere, also in Southeast Asia, in India, are the elderly patients with dementia, with memory problems. They don't remember whether they took insulin once or twice. And this is the reason why they often have hypoglycemia, which requires hospitalization.
Thank you, Dr. Lesek. Opinion of Dr. Jargas.
Atul,
yes.
this first study, the decode that Leszek did talk about, what is fascinating about it is that hospitalization is pretty common and 18% mortality. So any drug, we might be talking about those 800 odd episodes of hypoglycemia that these authors did analyze. And most of these authors seem to be from the Indian subcontinent, working in Birmingham. What is fascinating is it's almost 20% mortality.
Yeah.
And if you combine with what information Professor Lesger gave us in the second paper, hypometric, in many patients, hypoglycemia is not as symptomatic as we usually talk about. And we talk about patients getting tachycardias, right? Sweating. Yeah. And if you do not have these hyperadrenergic symptoms and you have hypoglycemia, it would not prevent hypoglycemia for causing neuroglycopenia and whatever damage that can ensue thereafter. So yes, this metric needs to be put in place while making the treatment protocols. As Professor Leszek very rightly said, in Poland, sooner or later, they might use lesser sulfonylurea, but not in India. And particularly, glimepiride or glyclazide. But to my mind, over decades, I have seen last 40 years, I have never in my whole life given a full dose of sulfonylurea to a patient. Like, in the olden days, we used to go glibenclamide 20 milligrams. There is not a single prescription that I have written in my whole 40 years of endocrine practice. I would stop short at 10. And would start at that semi-euglycon and semi-glinase, 2.5 milligrams, because we were aware of it. Probably in younger people who are not having significant comorbidities, 50, 55, we can look at that ideal situation. But the moment a person crosses 70th birthday, I think, we will be doing more harm than good. Now, in second paper or in third paper, what professor said, what was discussed there also, an incipient episode of hypoglycemia, incidentally, whatever the factors, counter-regulatory hormones, lethargy or whatever, the duration of hypoglycemia lasting during night time is almost twice than lasting during the day, whatever the factors responsible. And we know from the whole published data that sudden spontaneous nocturnal death is twice common in diabetics than in non-diabetics. So I think if you take the total, all the three papers, yes, I do optimize 55, 60, but start relaxing a little bit as you cross 65. I look more at comorbidities, prevent cardiovascular disease, give good statins, renal disease, shift more towards gliptins and SGLT2 inhibitors if there are no contraindications. And if there's obesity, if there is no monetary constraint, let's say we have a monetary constraint also here for GLP-1 receptor agonists, particularly in the long run. But there's a sizable population who can afford it. So slowly and steadily start shifting in that direction. And if we do that, we will not eliminate hypoglycemias totally, because still a big chunk of people would need some amount of insulin. Missing a meal, overtaking the insulin, misjudging the dose, and slowly with time having lapses of memory, and some amount of memory loss, whether I took a drug or not, whether I took the insulin or not, episodes of hypoglycemias would continue to occur. So we need to be on guard, keep the family members informed about it. But if we slowly, smaller dose of sulfonylureas, progressively increase gliptins, SGLT2 inhibitors, if possible, GLP-1 receptor agonists, we will minimize the whole thing, but we will not eliminate. This 18% might still be 8%, but 10% is good enough to say.
Thank you, sir. Thank you, sir. Thank you, sir.
Yeah, the comment on, if I may add briefly, the comment on the doses of sulfonylurea, I guess, is especially important. In Poland, we have glimepiride registered to be used up to 8 milligrams per day. I never prescribed 8 milligrams. The maximum dose I go is 4. And I usually prescribe 2 to 3 milligrams, and that's okay. That is enough. And the higher the dose, it doesn't really improve glucose, but may cause sudden drop in glucose, sudden hypoglycemia. So this is the same with glycoside. We use rather 30 or 60 rather than 120. Yes. So
Thank
that's
you,
an important remark.
Sir, there is another important thing Dr. Lesjak has presented, that most of the time, type 2 diabetic patients and type 1 diabetic patients, they are having overlapping things. Like in the form, some of the type 1 diabetes are obese and some of the type 2 diabetes are lean and thin patients. And the chances of diabetic ketoacidosis will be more. So, sir, I think first I will ask the question from Dr. N.K. Singh, sir. Sir, N.K. Singh, sir, please unmute yourself. Sir, do you think that at the time of the diagnosis of whether type 1 or type 2, type 1 is definitely no question, but also on the type 2 at the time of diagnosis, do you consider they take the help of these different types of antibodies to confirm that you are dealing a case of type 2 only, not the type 1 type? So do you think that in all the type 2 diabetic patients, at the time of diagnosis, the antibodies must be measured, or it is just a clinical thing?
This is very tempting. This is very tempting to measure autoantibodies. The issue is the price of the test and its availability. But and this is the report from many centers, because they have been more accessible in many laboratories nowadays, especially anti-GADs. And the more you measure them, the more often you find them. So I guess we have to wait a few more years to have very clear recommendations. But as I said, we have a paper from September issue of Diabetologia saying that we really should follow these patients and basically encouraging us to measure autoantibodies. The call for this comes from pediatricians. Pediatricians measure all sorts of autoantibodies, but they have very low number of patients. They can afford it, and I guess there are usually more money for children than for adults. But this is the direction we are going. I don't think it is a problem when we have a doubt. Like I see a patient, type 2, I think type 2 diabetes, but not obese. Perhaps this is something we used to call LADA. The challenge is when we have an obese type 2 patient, I mean diagnosed as type 2, who eventually appears to be type 1. This is always surprising. So yeah, wow, 35-year-old man, 130 kilos, and when we measure anti-Gas, they are very, very high. So this is something new in a way, which we have to find out how often it occurs. So yeah, we will still be discussing diagnosing diabetes for years to come. It's not a closed chapter.
Thank you, Dr. N.K. Singh, sir. Your opinion, sir.
Yes, sir. I think, sir, Dr. Atul, sir, you have raised a very, very valid problem which we are facing these days. Because these days, sometimes definitely there is becomes very difficult to say whether we are dealing a case of type 1 diabetes or type 2 diabetes. And in my clinic, lots of young patients are coming, and definitely they are all not type 1, but that time it is very difficult in Indian settings, sir. Jari, you are asking that we could go for universal screening for antibody. It is not possible at all. Many cases of ketosis-prone diabetes you are also getting. So my thing is that clinically we should go for that. That first, let us see what have been happening with the oral drugs, and if there is some ketosis-prone diabetes, the initial test which I plan that to do a C-peptide after control of the diabetes. And when there is, suppose there is insulin requirement is going day by day less and less, then I don't think such cases are going to be a case to be a type 1 diabetes. So I think in Indian setting, it will always better to go for the clinical age and have clinical orientation that we will go for seeing the clinical pattern of the cases, the age of the patient, the BMI of the patient, the family history of the cases. And even if there are many cases I have seen recently coming with young age and with decay. But after 2 or 3 months or 6 months, I found that there was no requirement of insulin at all.
But NK, they may be in the honeymoon phase also.
Right.
Yeah,
I mean,
so
you
I
may
think
not
in
say
fact,
that.
yeah. So in those cases, it will be very difficult, but well, even then you are suspecting that it could be a
I
case
mean,
of type
young
1
type 2
diabetes.
diabetic patient, we must see the insulin resistance, signs of insulin resistance. They will
That's
have
that's the
obesity,
clinical.
family history, acanthosis nigricans, their liver may be increased in size. So, I mean, that will be more typical. But type 1 patient will typically present with significant weight loss, with all typical symptoms of polyuria, polyphasia, polydipsia. I mean, C-peptide can be done. That's not very costly. We can't afford for all our patient at least autoantibody. But definitely autoantibody testing once in lifetime makes sense to confirm the diagnosis, because diagnosis of a disease is very important. When you are suspecting between type 2 and MODY or a young patient with LADA or type 1, I think it's better to send the genetic analysis also. People don't remember and don't know that there is a free testing can be done genetic analysis in India by ICMR Advanced Center for Genetic Analysis. You can just send your blood sample for a type 1 or suspected MODY and you can get free report of that. I mean, that facility is not available in many parts of the world. So it's not necessarily that it's a confusing. We can definitely diagnose them. There is the importance of clinical history on examination properly, and you can diagnose and differentiate between these three conditions.
I think
Exactly,
LADA
Dr. Bansi,
becomes very, very important.
Yeah.
To differentiate, LADA becomes very, very important because LADA is one case which keeps on going on for a longer period of time and sometimes not diagnosed well. And therefore,
That's
these
what
are the
we said.
patients.
Tejas, it's very important to invest some money for diagnosis. So it's a
Yes,
lifelong. You have to stamp someone that this is your condition and now you have to take this medicine only. Because,
absolutely.
sometimes you keep on asking a different medication, which is more costly and going to give more complication rather than putting some investment for diagnosis of the condition.
And
And if
we
we
see,
all
and
will
we,
start doing autoantibody, I'm sure in a few years only it will become very cost effective for most of our patients.
and we see GAD positive even at a later age quite commonly now. LADA is seen with GAD positivity also. So it's important to diagnose them early. Agree.
Thank you. We are running short of time. So one question to Dr. Tejas. Actually, Professor Shashank Joshi has very clearly mentioned about the MASLD and the link of the MASLD with the cardiometabolic risk in the patients. So do you think that, and it is a very common disease. If you do the ultrasound, lots of about 70% of the patients are having different stages of the MASLD. So, sir, do you think that in these cases where there is a stage 2 or a stage 3 liver disease, do you think that there is a screening of this cardiometabolic disease must be done in these patients, especially if the role of echocardiography for epicardial fat and other risk factors to rule out other risk factors? Do you think that it should be routinely done in the advanced stage 2 or stage 3 fatty liver disease in general sense, you can say?
I think absolutely. As the years are going by, we are learning more and more about MASLD from what knowledge we had few years back. The classification has changed. We now terminology has changed, and now we very clearly have a diagnostic way of how to go about it. Simple tests like just assessing the FIB score first, assessing the stage of the patient, and then going on to the further. If the FIB score is more than 1.4, then you go on to diagnose and do the other test, as Dr. Shashank Joshi also showed in his presentation. And then once we know that these patients are at this stage where clearly they are progressing toward a stage of fibrosis, I think it becomes important to assess them for cardiovascular disease also, because like we were talking about microalbuminuria as one of the cardiovascular risk factors some years back, now MASLD is going to be considered to be as one of that. And I think slowly and steadily we are moving towards that stage where we will be screening all these patients for an underlying or a silent cardiovascular disease. So I think it is one of the marker, and of course we know that the treatment is that of making them lose weight, making them lose fat. That itself will break that cycle where they will progress towards either type 2 diabetes or a cardiovascular disease.
Thank you. Thank you. We are running short of time now. Only 1 minute is left. Over to Dr. Banshi Sabu for final comments on this session. Dr. Banshi, are you here?
So I'm sorry, first of all, that my video is not working. Even Vishal had tried, but I don't know what happened to my desktop. So today, please bear with me. And before we end, Lesjak had already left because he has to see some patients. Shashank is busy in clinic. I am also in the clinic, but I finished my patients. So I will request first, Amit, that we can have our video, which we can show, and then Amit will be also talking about the EASD, and then we will formally close by Dr. Vishal will close it. Over to Amit.
Thank you, sir. It is with great privilege and proud that we present to you the teaser for the Diabetes India Congress, World Congress of Diabetes, which is going to happen in Ahmedabad in the month of February 13th to 6th. And I will just seek attention of Dr. Shashank sir. He is the Chief Advisor of Diabetes India. So just to launch this video along with Dr. Bansi Sabu, I will request the RX team to play this video of Diabetes India event.
Re 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 jindabad re jindabad re Ahmedabad Baba joda je wo tofani re ke swabhimani re नगरी छे कांटाओ माए उछरी छे गुजरी छे लाखों चक्रव्यूहों थी पार हमेशा उतरी छे खट्टू मिठू ने तीखू शहर रे के लीला लहर रे रे अहमदाबाद बाबा जोड़ा जे वो तूफानी रे स्वाभिमानी रे रे अहमदाबाद जानो ससो कुत्ता ने डारे रे ने पाछो मारे रे
अरे कुछ दिन तो गुजारो गुजरात में.
Nice. Thank you, RX team, for playing that video. Now, Shashank sir, your comments and your guidance, please, and then Bansi sir and Vishal can close the session.
Amit, thank you so much. I'm sorry I was very busy my clinic and I had to also for that spurious ducks to be on times now. So I congratulate all of you and I'm looking forward to seeing everybody in Ahmedabad 2 days from now and again for Diabetes India World Congress in February. So I wish that everybody sends their original work from India because we are on a mission to generate more evidence from our population. And I sincerely appeal to everybody to generate as much evidence as possible. I'm certain that the learnings today will help us for people living with diabetes and their complications and the update from EASD. And I think I want to just end with the topic which I said that we are now into triangle of care. So it's not just about heart and kidneys, but liver has got added in the triangle. And let's not forget that. And I think the quadrangle will come from the brain. So I think there are 4 areas which we need to look after for people living with diabetes. One is the heart, second is the kidney, third is the liver, and fourth is the brain. And I wish everybody a very happy good night and stay healthy and happy. So thank you so much, Amit, for coordinating it, Bansi and Vishal and his entire team.
Yes, Vishal, you can give vote of thanks.
Well, sir, first of all, looking at that video, I am sure we are going to have the best Valentine's Day. The coming Valentine's Day is going to be the best in the life that we have attended. So, good evening, everyone. Myself, Dr. Vishal Vaidya, and I am deeply honored to be a part of this discussion. On behalf of all the attendees, I would like to express our sincere gratitude to our distinguished speakers, Dr. Leszek sir and Dr. Shashank Joshi sir, for their informative and insightful presentations today. The information shared on the topics how to best prevent and manage hypoglycemia or decay and targeting MAFLD for CVD protection has been incredibly valuable and will certainly help clinicians and diabetologists around the world, I'm very sure. I would also like to extend our appreciation to Diabetes India, as well as the experts for today, Dr. Amit Gupta sir, Dr. Atul Kulshrestha sir was the moderator, the panelist, Dr. Zargar sir, Dr. N.K. Singh sir, Dr. Tejas Shah sir, and of course, Dr. Bansi Sabu sir, for their hard work in coordinating this event and ensuring a seamless experience for all of us. We encourage all our attendees to reach out to us if you have any additional questions or you would like to provide feedback on today's webinar. Once again, thank you all for your participation and attention today. We look forward to the next session tomorrow for valuable insights and learning opportunities. Dhanyavad. Jai Hind. Thank you very much.
Thank you.
Thank
Good
you.
night.
Great.
Good night, Vishal. Thank
See you
you.
tomorrow evening.
Good night. Good night. Good night. Good night to all.